Great, welcome back. So this is my second 3-hour slot, just to talk through the research side of things. So it's worth starting with this. And this is a kind of a graphic of the publications in the medical literature about SCAD. And you can see, I think I wrote a little review article on SCAD in 2010. So I was one of few people back then. But you can see what has happened since. And of course, this is exciting and important for everybody in this room and everybody who's watching the video online, because this is really how we make progress. Progress is all about collaboration. It's all about a huge number of people, some of whom you're going to meet because they're going to give little introductions and talks about what they are doing. Some of them you won't meet. They're the kind of, if you like, hidden gems that are grafting away that you might meet in clinic, who will talk to you about studies and consent for studies and things like that. And also those people that are beavering away in the biobank with your DNA and extracting that and so on. And these are people from not just in Leicester and Edinburgh and London, but from all around the world. We got our registry started with support and help from our friends and collaborators in the Mayo Clinic in the US. And we've since gone on to help and support SCAD registries in many European countries and internationally to get going. But I think this is really exciting and really encouraging, because if we can keep this curve heading upwards, that's how we're going to make a real difference. So what is the research strategy, if you like? What are we trying to do and how are we trying to get to the bottom of this disease? And you can tell that I drew this because it's rather naff, isn't it? But anyway, just to give you an idea of what we're trying to do and how it flows. So if you like, at the top of this is genetics. And I'll talk to you a little bit about genetics in a minute, and what we know about genetics from the perspective of SCAD, understanding why it is that the people in this room are so special. We all know that you're special. We can tell that. We've met, we've chatted over lunch. But what is it that's particularly special about you that's landed you up in the BA-SCAD conference? And we need to understand that. And then if we can understand what the genes are doing, if you like, they're your kind of background risk profile. What the genes do is they then make proteins. They make bits of your body, essentially. They make the building blocks of your body. And of course, the hormone side of things also, you know, we're looking around in the room and we're thinking that there's more ladies with SCAD than men by quite a substantial margin. That doesn't, by the way, mean that the men aren't important, because they're extremely important. We're very interested in you. So if you are a chat with SCAD in the audience or online, then we need your help too, because you don't have hormones that are moving around. And that makes you particularly important from a research perspective, because you're, if you like, a more static in biological terms from that particular perspective. So we've got proteins, we've got hormones, and then we've got the cells. And the cells are then making up your arteries. And all of these things we are doing research on. So we're trying to understand the genetics. We're looking at these proteins that they make and the hormones that are circulating your body. You're going to hear all sorts of things around those. We've got people that are beavering away, growing cells from SCAD patients in the early days. Some of you provided little samples of skin, and we may ask some more people to provide little samples of skin from which we can grow out cells. And from those cells, we can then, you know, look and see and try and understand how cells work. So if you gave a little skin biopsy back in the day and you thought that that research had come to an end, it's not. Your cells are still there. They're still helping us to learn. And then there's the arteries themselves. And you'll hear a little bit later on about how looking at these arteries with ultrasound scans and trying to understand the differences in how the arteries work might give us some insights into why you are special. And then from that, we can understand the key questions, if you like, which is vulnerability. Why are some people vulnerable to SCAD? And what about the longer term risk? Can we identify those risk things? What are those things that lead to SCAD? And of course, the aim at the bottom of the tree is to come up with treatment solutions and prevention. And it's a long road, but sometimes there are shorter cuts than we imagine. So these days, sometimes you will find treatments, but they may be treatments we already know. It's just we don't know that they are beneficial yet in a SCAD population. So it's not necessarily that we have to, you know, find something that's completely new for SCAD. It may be that there's already things out there in the armory. And we need your help to do this. on multiple levels, and many of you already have provided help, but there will be other things as well. So a mace is obviously used as a blunt weapon, but not in the context of SCAD research. So mace checks are essentially where we drop you an email or give you a ring and say, how are you doing? And that helps us because we need to know how you're getting on and what's happened and has anything changed, have you had any other scans and things like that. So please watch out for those calls, those emails, those things. Hopefully it won't take more than a few seconds to just say back, I've been fine, nothing's happened, nothing's changed, I haven't had any scans or anything different happened to me, I haven't had a baby, or all these other little details of questions. But always watch out for a mace, even in whatever context. So for the next few moments, I'm going to be Rahul. Here he is. So you just have to envisage that sort of morphed change. So Rahul is a PhD student who is a laboratory scientist. So what he is doing is he's sitting with those cells that I talked about earlier. He's growing those cells up, studying those cells in the context of different people's genetics, and working out what that does in terms of how the cells work, how they make connective tissue, that glue that we talked a bit about earlier on that holds cells together, and also understanding genetics. And we've made a fair amount of progress in terms of the understanding the genetics of SCAD. So at the beginning, when kind of we and BA-SCAD formed our alliance, if you like, there was pretty much nothing much known about the genetics of SCAD. There were some associations with a few inherited diseases, but these were pretty rare. And what we've done since is, first of all, understand that those single gene disorders, one DUF gene moving through a family, is very uncommon in SCAD. It does happen very occasionally, maybe 3, 4, 5% of the whole SCAD population might have something like this. And just to help with your thinking about this, usually that will involve a significant family history of something like an aneurysm in the chest or a dissection of the aorta, those type of things. So significant family histories in near relatives is a suggestion. And sometimes we'll pick up things on the scans that might make us think, this is something we need to think a little bit harder about. But for most patients, these single gene things are not important. They are not what's going on. But what we have identified is that your genetics is a significant reason why an individual gets SCAD. So SCAD is quite heritable, but it's due to multiple risk genes that are occurring in an individual. And because each of those genes, if you like, for the child of a SCAD patient, each of those risk genes, a child only has 50% chance of inheriting each one of those risk genes. The chances of them inheriting in a big enough dose to themselves be vulnerable is very small, because they will always get 50% of their genes from dad, 50% from mum. So the chances of them collecting enough risk genes to be vulnerable is low. And that's the reason why SCAD running in families is very rare in the world. It doesn't never happen, but it's uncommon. Usually just needs extra thinking about. So supported by the research we've identified with our international partners, it's again worth emphasizing this. This is the Mayo Clinic, this is Vancouver, this is France, Australia, this is us as well. So lots of people around the world contributing to this. We identified 16 risk genes for SCAD that are to do with the glue that holds the arteries together and a little bit to do with the clotting. We think this is about a quarter of the total, and so we want to do this sort of research again so that we can identify more genes to get more insights into how SCAD works. Many of you will already have given a blood sample in order for us to be able to get your DNA. If you have not, and you are signed up to the registry, you may find yourself receiving one of these things in the post, which is a saliva kit, because we can now extract your DNA from saliva, and it's a lot easier to transport around and post and stuff than blood, which causes some issues and things. So if you haven't given a blood test before for DNA, watch out for this. Do a bit of drooling for us, if you wouldn't mind. But yeah, so just watch out for this, because what we think at the moment on the registry, about half of the people on the SCAD registry we have a DNA sample for, which means that we have the potential to basically double our sample size. if everybody provides a sample that hasn't done as yet. And we suspect that our collaborators internationally can also do this. And this kind of genetics research is all about numbers. The more people you get, the more genes come out the other side of it. And so internationally, our collaborators are poised to do this again, and we want to be the biggest, best contributor that there is, hopefully, in order to get those numbers right up, and so that we can come back in 2 years' time and hopefully tell you about even more genes and how they all fit together, and then we can follow that diagram down to the bottom. So cells and proteins, this is what Rahul is doing. I mentioned a little bit about this already, so some people have given some skin biopsies, and we've previously done electron microscopy to try and look and see if we could identify particular things around the connective tissue around these cells. But the real focus around the cells these days is growing them up and then looking to see how they work. And there is a new thing which we're hoping that we're going to be able to do. We're trying to get some funding together to do this right now, which is where you can take a skin cell and you can grow it in some particular chemicals that makes it go back to when it was born. Imagine that. So it becomes a stem cell. So you can take the cell from a skin cell and make it go back to being almost like it was the day that that cell was made. And the advantage of that is that we can then take that skin cell and make it into a blood vessel cell. And then we can study the blood vessel cell and see how it works. So again, thanks to those who have already given little skin samples to contribute to this research, and there may be some other things. It's not everybody that wants to do that kind of thing, but it's hugely helpful because, as you can imagine, this gives us the tools that are making up the blood vessel to study. And then what we can do is this kind of thing, which is very complicated. I'm not going to test you on it later, so don't worry. But what you can do is, this is the whole world of artificial intelligence. And what you can do is partly that, but it's also what we call omics. And that's where you take the genes and you take the things you can measure in blood and you take the proteins, you take all of the data that you collect and you give it to the computer and you say, what causes SCAD? What it does is it makes these links and it makes these connections. And we've started to do this a little bit. And it doesn't really matter what these things are, but what you'll see is col, which is collagen. Collagen is one of the constituents of connective tissue. And so what it's showing you is that the things that come from these analyses, they make sense. And so we can start to try and put that together to really understand what's going on here, what's the underlying problem. And what you can also do, and you can also feed into these kind of analyses, what we call druggability analyses. So you say, okay, so there's all these bits that are involved, but how might we be able to change those bits in a beneficial way? And you can actually ask it, and it will spit things out, and it will say, actually, medication X, which already exists, might be something that you might want to study. And so that's what you can get from the genetics, the proteins, the cells. All of those things can come together, even in relatively smaller numbers, to give us insights to really get to the nubbin questions that everybody always asks when they come to the clinic to say, well, why did it happen? What's the problem? What's the underlying cause? Clinical trials, I said this a little bit earlier, clinical trials are critical because it means I don't have to flannel anymore, which is good. It means that I can say with much more certainty which medications are good, which ones are not. So there's a clinical trial which I mentioned already, which is BA-SCAD, which has finished recruiting in Spain, looking at high-intensity, low-intensity antiplatelet therapies. Those are the aspirins, clopidogrels, ticagrelors, prasugrels that many of you will have come across. And also looking at beta blockers, yes or no, in an open design. This will be the first clinical trial in SCAD that will be published. And the Spanish guys have done brilliantly with this, and also the Spanish government, which invested €1 million to do this clinical trial, also very far-sighted in that investment. I think we might hear something from BA-SCAD in a couple of years. And of course, BeatSCAD website will be the place where we will post information about these things. BA-SCAD, because it's a single national study, will be quite small. I mean, I think it will certainly give us more information than we have now, by far. But there is also an initiative that we are involved in the UK, which is called APT-SCAD, which again is looking at high-intensity, low-intensity antiplatelet regimes, trying to understand those. This is international, and will involve most of the countries that currently are interested in SCAD research, and also includes us. So we will hopefully be looking to recruit 500 patients. There won't be patients in this room because these will be patients who are recruited at the time they're in hospital, because we want to understand from the very beginning whether these medications are beneficial. But again, I've been hugely encouraged by the fact that already, even though at the moment we've got the funding, and the funding comes from the British Heart Foundation for this study, we're very excited and grateful to them for that. But also, I'm very grateful to colleagues across the UK. 65 centres so far have signed up to it, which again shows you that it's not just us in this room, but also the equivalents of me in hospitals all around the country who want to know the answers to these questions so that they can be treating you in the right way. APT-SCAD is funded by basically the British Heart Foundation and its equivalents in these countries, and the BHF has awarded more than £1 million to support the UK effort towards this clinical trial. So this is a really exciting time for SCAD research. It's going to take us time to get to the end of each of these journeys, but it's massively important that we've started them. You know, we have 16 genes. I'm hoping we can double that. We have a first clinical trial that's going to report soon. I think there will be more to follow. I'm going to introduce you now to some of our SCAD researchers in the UK, and they're going to talk to you a bit about some of the work that they're doing and the amazing progress that they are making. It won't be final answers, but hopefully just gives you a flavour of the stuff that's being done. So first, I want to introduce you to the amazing Professor Neubeck, who's been instrumental, really, in helping us to get the clinic up and running and started in Scotland. It's still a battle up there to keep that clinic going. It's a battle everywhere. But also many of you will have been involved in the research that she has been doing into SCAD, and I'm going to hand over to her to take you forward with some updates on that.
Thank you very much. So what I thought I'd do is just tell you a little bit about our journey and how we got into SCAD, because I wasn't a SCAD researcher. I was a cardiac rehab nurse by background, and I started looking at people who don't go to cardiac rehab and why do they not go and how can we help them, and became really interested in digital tools to support self-management of cardiovascular disease. And I was speaking at a conference that the British Heart Foundation had organised called Beating Bias, which was about women and why women don't go to cardiac rehab. And there's some good reasons why women don't go to cardiac rehab, apart from the fact that everybody's 60, male and white. So we know this is a predominantly female condition. Somewhere around 90% of people with SCAD will be female, and it accounts for overall about 4% of acute coronary syndrome cases. When I started in this, and I started because I was talking about women don't go to cardiac rehab, two women in the audience, Margaret Davis and Mary Galbraith, came up to me and said, if you think it's hard for women to go to cardiac rehab with regular atherosclerotic disease, what do you imagine it's like for those of us who don't have that when we get to cardiac rehab? I thought, oh, okay, right, I'll start thinking about that. So we did a systematic review. And this was the prevailing message when we started, was that there's an absence of cardiovascular risk factors. There was a high level of anxiety following events. That hasn't changed. But the current cardiac rehab just doesn't seem to meet the rehabilitation needs of women with SCAD. So, great, we're going to do some cardiac rehab for SCAD. And then I started going, well, where do SCAD patients in Scotland go? And they don't go anywhere, or they didn't go anywhere. So I chased Dave and said, Dave, what am I going to do about this? And Dave said, well, we need to start having remote clinics. We need to find somebody who's interested in this in Scotland. So I did some stalking. And so my stalking led me, first of all, to Beat SCAD, and I cannot say how important these guys have been to us. You guys have all been to us in terms of developing this. And as I say, my stalking also led me to Dave, and we had a conversation. And I worked closely with Nick Mills, who's a cardiologist in Edinburgh, and I said, Nick, who am I going to get to do this clinic? How am I going to actually champion this and bring it forward? And Nick said to me, I think the best person you could reach out to is Anne Scott. She's a consultant cardiologist and she's just moved to Forth Valley. And that takes you out of the Edinburgh-Glasgow rivalry, which I'm afraid does exist and makes things tricky on occasions. So Forth Valley, but also strategically location-wise, middle of Scotland, very easily accessible by all motorway networks. It has a train station. And then Anne introduced us to Claire Murphy, who was the director of the clinical services at the time. So together, Anne, Claire, Dave and I wrote an application for some seed funding from Scottish Government to develop and deliver this clinic for 2 years. And we've been running for exactly 2 years. So we launched at this time 2 years ago when I came to the clinic and we were talking about it. But I would also be remiss if I didn't acknowledge my amazing researchers, Dr. Carl Hansen and Alice Pearsons, who are integral to everything that we do. And Carl here is shown yesterday winning the award for the best oral abstract at the British Association of Cardiac Prevention Rehab conference for her work in SCAD. So together with these guys, we set up to have a clinic in Scotland. And Dave, who has the patience of a saint, came up to Scotland once a month for almost 2 years to deliver the clinic and to train Anne and Claire. And so this was reported in about March. So it's not a complete report of the whole clinic. So we had 90 referrals over 18 months. And by the time I collected the data and did the reporting, I had data for 62 patients. This is a huge challenge. Data collection is a huge challenge. Getting people to enter data is a huge challenge. And I'm dreading to go back and look at the next 6 months to collect the rest of that data. But I'll just tell you a bit about it. First of all, we recruited people from every single health board in Scotland. So that was really gratifying. People came to us from Orkney. They came from all over Scotland. And the interesting thing, I think, is that the majority of people wanted to come in person. We offered an online service, but they actually did want to come for that first clinic. And this just shows quintiles of deprivation in Scotland, reported as SIMD, so Scottish Index of Multiple Deprivation. Patients came from every demographic. We didn't just get people who were well and able to access the service. We got people from a variety of areas in Scotland, and that's incredibly important because cardiac rehab doesn't. Cardiac rehab gets people who are well educated and gets them to come, and typically they are men who have bachelor degrees and they do very well in cardiac rehab. But what about all the people who can't get cardiac rehab? So we had some fun setting it up. We set up a national referral system. You could either email Leicester, and patients who got emails to Leicester were repatriated to Scotland. You could email directly to the Forth Valley Clinic, and we take referrals from any healthcare professional. So absolutely anybody can refer. We had a little bit of fun and games trying to get access to national portals. We're able to see all angiograms across Scotland. We're not able to see all echoes. So that can sometimes be a little bit of a challenge. But we also need to ensure that people get appropriate screening beyond that initial service. We're able to collate all clinical data, and we have got access to imaging. So what happened? Well, of the patients that came to see us, we revised the diagnosis in almost 30%. That means we're not quite brilliant at getting SCAD right in Scotland. So a number of patients came to us with other conditions. Sometimes it was appropriate that they were seen by us because there are things that are very similar to SCAD that need an expert to tease out. But sometimes people who had had traditional atherosclerotic SCADs, who were very classical in their presentation, still found their way to us, and we were able to give them an appropriate diagnosis and refer them back. But of course, the majority were SCAD, so that is good. Of the patients who'd come to us, 79% have been referred to cardiac rehab. I'll talk a bit more about that because not everybody went. And I'm really pleased to say that there was 100% patient satisfaction. So the patients thought it was amazing. The doctors thought it was pretty good. One doctor wrote to us and said it was terrible, but he hadn't referred a patient to us. He just didn't like that we'd started it. We revised medications. So in the paler blue, you can see the number of patients who were on statins before they came to see us, and we decreased a lot of statins. We only kept people on statins who were on them either because they had a comorbid condition that would justify it, or they had cholesterol high enough that it would be justified for primary prevention. We also increased the number of patients on beta blockers. Now, this is a very crude back-of-an-envelope calculation based mainly on the costs of sending Scottish patients to Leicester. But the Leicester clinic is actually slightly more expensive, possibly because Dave talks more than Anne, I don't know. But we essentially, every year save 22,000 by having patients stay in Scotland instead of coming to Leicester. And these are not overinflated costs at all. We haven't done a full health economic analysis, and I would like to do that going forward, because I think that's really important, because we haven't taken into account the time that people have to take off work. We haven't taken into account other factors that relate to this. All we've looked at is change in medication, the equal costs of the clinic, and the cost of transport and accommodation, which Scottish Government sometimes picks up, or at least the local health boards sometimes pick up. So that is the Scottish Clinic. Now, the bad news is that we are in a holding pattern at the moment. Having had 2 years of successful funding, we think we found an interim solution. But I can't quite say because it's not quite official yet, but I think we found an interim solution. But any Scottish patients in the room, if you want to reach out and say how important this service is, then please feel free to do so. Neil Gray is the Cabinet Secretary, Jenny Minto is the Minister for Women's Health. By all means, tell them. If you've been and you thought it was worthwhile going to, let them know. And if you would like to access a clinic like this and continue it, then let them know. So this is where I started, before I found there was no clinic in Scotland, was how are we going to develop something to help people recover? And we wanted to develop something that was patient-centred, contain education and support that people told us they wanted. It had to be flexible and adaptive. And I'm a digital health nut, so we thought it needed to have technology embroiled in it. And we got successful funding from Burdett Trust for Nursing, so charitable funding again, to run this pilot study. So we recruited 26 patients, thanks to all of you in this room who participated in that initial bit of work. We did questionnaires trying to understand what it is, what was people's personal experiences, what sort of information would they want, what psychological impacts, what do they need in terms of supporting physical activity. And we had great conversations 2 years ago about what types of things people thought they would need. And one of the most surprising things that came out of this is if you look at a wearable device, if you had one before and you had one after, is you might find you're actually doing as much exercise now as you were doing before. People just didn't appreciate how much they were doing. So it was a really interesting little finding for us. So we co-designed an intervention, and this is what people in the community told us they wanted for this intervention. So they wanted an early one-on-one session. So as soon as they were referred to us, they got to speak to a specialist nurse, who's Alice. Alice obviously has developed specialist SCAD knowledge through lots and lots of conversations with Dave and all the work that we've done together. We gave them advice on recovery expectations, advice on managing symptoms, and this was ideally delivered before they got to see Dave. So this was a kind of, right, we've got to give you something to help you while you're waiting to get to see Dave. We gave medication education and advice, early signposting to the BA-SCAD information and specific information that they might be asking. They had an opportunity to ask clinical questions, and we had Dave on the end of the phone if we didn't know the answer. We've been asked some really, really fascinating things that we didn't expect. We've had to learn about cold water swimming. We've had to learn about oboe playing. We've had lots and lots of interesting things that people have asked us that we didn't necessarily know the information about. Talked to them about mindful activities and navigating cardiac rehab. We've also done a lot of work over the last 2 years going out and speaking to healthcare professionals, and including the British Association of Cardiac Prevention and Rehab, to try to upskill them into delivering the right sort of information for people with SCAD. And then after that, they had a phase 2, 8-week virtual program led by Andy, who is a wonderful exercise physiologist. I think every comment says Andy was amazing, Andy was amazing, for any of you who actually got to speak to Andy. So they had 5 sessions with Andy, and it was a virtual conversation with somebody who has exercise specialist knowledge, but it predominantly focused around behaviour change, around understanding what your limitations are, understanding what you can and can't do. There's very little you can't do, as far as we know. At the moment, the consensus around exercise, no disrespect to cardiologists, but it's been developed by cardiologists, not by exercise specialists. So now we're beginning to get into the mix and trying to help to make this understanding. And I'm going to hand over to Noemi after this, who's going to tell you a little bit more about our study that we're ongoing in doing this, and we're using this as part of that information. So goal setting, motivational interviewing, and there was an optional use of a wearable for this program. So we recruited from Leicester and Forth Valley from people who were on the waiting list to see the various consultants, and we sent out pre-consultation measures, questionnaires, pre and post exercise, counselling intervention, and we did a remote walking test, and there are reliable remote walking tests we can use. As I say, we had the use of the Fitbit if people wanted it, and I'll tell you about uptake of that. So, patients we screened, 51 were eligible and 32 consented. Of the 32 who consented, we had 24 who completed the whole programme. So there's a fairly high engagement and retention, higher than cardiac rehab, I have to say. So the participants' characteristics. Now this, of course, will be interesting because this is what we'd also found in the systematic review. Obviously, majority were female. Mean age was 55, slightly higher than the literature, but roughly about the same. 82% had only had one SCAD. There was a history of previous smoking amongst 36 people. Half of our population were overweight or obese. Almost half had hypertension. 43% had dyslipidemia. And I think these things are really, reflective of what we found in the literature. SCAD is not necessarily a condition of no risk. There may be some mechanisms here that we can address to support it. But this is just what's in the general population. This is not any different from general population. Only 43% went to cardiac rehab, and a large number of them reported to us that cardiac rehab hadn't been suitable for them in the format that it was delivered. The majority of patients used a wearable. So I think 43% had a wearable at the start. Quite a lot of them requested a wearable from us as they were going along. Even if they turned it down at the first instance, they then took it up, and they found it very useful. Wearables are really helpful, except when people psychologically go, I'm not going for a walk today because I haven't got my wearable on, so it doesn't count. It still counts, even if it's not being recorded. So, outcome measures. The 6-minute walk distance increased on the use of objective measures. This was another interesting thing. People wanted to do the 6-minute walk test even when we weren't measuring it, because it helped them feel that they were improving. Mental well-being improved on the WEM-WS score. So pre versus post score, it was helpful and beneficial. People improved their mental well-being. We are doing large studies with colleagues in Canada. Myself and Dave are part of a team who are looking more at the psychological impact of SCAD and how we might use it. And general self-efficacy improved through this as well. So the conclusions were that this high completion rate suggests this intervention is highly acceptable. It might be a potential solution for other women, back to my very first point, who don't go to cardiac rehab, and how can we support them? We didn't focus on exercise intensity guidance, so this is the perfect moment to hand over to Noemi, who's going to tell us how we're going to understand this. And this study is funded by Heart Research UK, and Coral Hansen is the principal investigator, so Coral continues to champion the exercise arm of any SCAD research. So I will hand over with that to Noemi.
Thank you very much. Yes, so my name is Noemi. I have a very long and confusing surname, and I have a very long and confusing job title. But really, I'm just a postdoctoral researcher who's interested in helping people to, after a life-changing event, and get back to live your life as full as possible. So I thought I would clarify a few things before we go into exercise and SCAD. What is really physical activity? Physical activity is kind of any bodily movement that is produced by skeletal muscle. So right now, believe it or not, I'm being physically active by standing up somewhat straight. And exercise is kind of a subset of physical activity. So exercise is always planned, structured, and it usually aims to improve your fitness. So cardiac rehab usually has an element of exercise in it. And in 2019, the government released some beautiful, very colourful guidelines for us to follow. And according to these guidelines, we should all do 150 minutes of moderate intensity exercise and 75 minutes of vigorous intensity exercise. And that is all beautiful when you have the time, when you're healthy, and when you're not going through something like recovering from SCAD. But I think there's a very important message that gets lost in these guidelines, and that is, if you look at the graph, this is a dose-response curve of the health benefits on the y-axis and the amount of time you spend exercising on the x-axis. And you can see that it plateaus around 300 minutes per week. So really, you're not gaining more by doing more after around that 300 minutes. The most you gain actually when you start, and I think that's a very, very important message when you're just recovering from SCAD, that every single minute counts, and it doesn't matter what that is, as long as your skeletal muscles are contracting. It genuinely doesn't matter. Every single minute counts. If it's 5 minutes, it's 5 minutes. If it's 10 minutes, it's 10 minutes. And those little messages there in the corner about minimizing sedentary time is, again, very important. So when you hear this from a healthcare professional saying you need to be active, yeah, that's fine, but don't necessarily get discouraged by these guidelines. Every single minute counts. What does the research say about SCAD and exercise and cardiac rehab? Well, this is very much just a repetition. We only have 3 studies, really, that looked at cardiac rehab and SCAD, or in a SCAD population. And this is very important for us researchers, really, that none of these are randomized control trials. And that is important, really, from a research quality perspective. If they're not randomized control trials, we can't compare a group of people who are exercising with a control group. So our evidence is not really good. And only one study looked at SCAD-specific. I know that's changed now. I do apologize. Only really one study up until, I think, 2022 looked at SCAD-specific cardiac rehab. And again, I know this has changed now, but this is American data. 24% of SCAD patients do not take up cardiac rehab. This might be different in the UK now, as we learned. But what we do know at the moment is that cardiac rehab and exercise is likely to be safe. And yes, it can improve psychosocial factors, and surprise, surprise, it will improve your fitness, and it can reduce major cardiovascular events. But as we know from Professor Neubeck's research, traditional cardiac rehab, as it is at the moment, is not appropriate, and anything we design will have to be SCAD-specific, tailored. We have to try and use technology to help you kind of monitor yourself, and we need to implement some kind of psychosocial support. If you do need to look at the studies that I'm referring to, then feel free to use the QR codes in the slides. So that is what we are doing at Leicester. We are doing a randomized control trial. This is currently recruiting. And really, we are interested in 2 things. We're going to investigate a 12-week remote exercise program. This is going to be remote, so you don't have to come to Leicester to face talking to me in person. We can do that over the phone. And really, we will want to try and understand a little bit more about the relationship between physical activity and SCAD and its symptoms. So again, if you're interested in the study, we are registered with clinicaltrials.gov. The QR code will take you to the study itself. But then again, you will receive, quite likely, an email or a call from me. I'm really sorry if you already have done that. But you will receive an email or a call or a post to invite you to participate. Okay? If you're happy to participate, you will be randomly allocated. This is a randomized control trial, randomly allocated either to the control group or the exercise group. I have no influence over this. And if you're in the control group, you will get a Fitbit from us. You will get it posted, or you can get it from clinic when you see Dr. Adlam. We might give you another wearable if you're happy to wear 2. I will train you up to use a chest symptom app. So that is an app which will just allow us to see what your symptoms are, and we can set the symptoms specific to you. I know we talked a lot about chest pain today, but it can be anything that you personally experiencing the most since your SCAD. It will ask you whether you had a symptom on a specific day, and if you had it, how did it feel on a scale of 0 to 10. So this is if you are in the control group. If you're in the exercise group, we will ask you to do all of these things. So you will get at least 1 Fitbit and then maybe another wearable. You'll get some questionnaires at 3 different time points. But we will also do an exercise test with you. And this is an exercise test here at Leicester. I was told that this was a successful visit. So this is a gold standard for assessing somebody's fitness. There's no better way of assessing someone than putting them on a bike, looking at their heart and how their heart and lung function. In this study, we have done this with 7 people, and so far, we didn't have to stop anyone, so that was great. And previously, I think Dr. Wood has done about 50 of these tests, so we know that they are safe and that we can do them. We will also do some strength tests with you. And based on this, I can give you a bit of a program to follow in the next 12 weeks. And we will keep in touch over the phone. So there will be at least 5 supportive phone calls in the study, but it can be more if that's what is needed. So it really is centered around you and what you will need. And last, I thought I would finish up with general advice. So if you are at the start of this SCAD journey and you are a little bit scared of being active or exercising, then some of this is really self-explanatory. So really you can just see how your body reacts to being physically active. And that generally anything, as long as you're moving, shopping, gardening, whatever it is. And just remember that the start is where you get the highest health benefits. And it's really amazing how many things we can learn about from basic fitness tests. So I thought I would show you 2 fitness tests that I think Liz has already kind of referred earlier on. So one is the 6-minute walk test. The reason I thought I would pick this one is because it's used by cardiac rehab quite widely, and it correlates okay with the gold standard kind of exercise test that we are doing. So if you're not sure, there are apps. I'm not supported by these apps. These are free apps. They're freely available on Google Play and Apple. It will just time you for 6 minutes. If you go outside and just look at how much can you walk in 6 minutes. See how your heart reacts to it, see how you are, and do it in 2 weeks' time. See how you are in 2 weeks' time, or see how you are in a month's time. It really will just give you an idea. The other one is the chair test. It's really a lower body exercise or like a strength test. Again, all you need is a chair that is well supported. Do it for 1 minute. See how many times you can stand up for 1 minute, or see how many times you can stand up for 30 seconds. Again, it correlates well with gold standard measures, and it's just really an easy way for yourself to look at where you are and do it a couple of times to see if anything has changed. Thank you.
Thanks very much. So I think one of the things that's really important, so first of all, this exercise study is really important because we need to understand what we can do safely, and also how that process helps with symptoms and recovery. So we need to try and work out, what people's exercise was like before and what that recovery trajectory is. I think it's really important with this study to understand that this is not about athletes like myself. I don't know why everybody laughed at me. This is about rehabilitation and recovery for the whole spectrum of people who have SCAD. We know that within that, there'll be some people that come into their SCAD as, almost athletes, and there'll be some people that come into their SCAD a little bit closer to where I'm at, which is, maybe 4 or 5 steps a day at the moment. And all of that is fine, and everyone can participate in this study. In fact, it's really important that we get everyone to participate in the study. So, if you get a call, please don't be worried that you're going to be asked to do something that you can't do, because the whole purpose of this is for us to understand what the spectrum is of what people can do, and also to understand. So there's been quite a lot of kind of feedback about rehabilitation and the limitations of cardiac rehabilitation that people have experienced. And we can only make that better if we understand what works for you. What is the activity which works for you, and how can we deliver that in a remote way to the places where you are, rather than having to get you into a physical location. So please do support that. I'm going to do another couple of my steps back in this direction. I think I pulled something that time. Welcome to the stage, Charles. Charles is an RAF clinician who has been working with us, he's been interested in SCAD, he's been working with us for a little while now. And his focus, if you remember from the morning, I said, we need to change the diagnostic paradigm for SCAD. We need to try and see if we can change the approach away from invasive angiograms to maybe non-invasive scans. And Charles has been particularly interested in looking at those non-invasive scans to see what's possible.
Yeah, good afternoon, everyone. Thank you very much once again for inviting me to be part of this really wonderful conference. And I just reflected on it during the morning, and then as the day went on, this is the first time I'm actually delivering my research to non-clinicians. And it's been really sobering, actually, seeing how the impact of the research that we do and also listening to what the journeys really you've been through before I get to see your CT scans, which is what I'm going to talk about. And so, yes, thank you very much for offering your time and, yourselves for us to study to try and improve our understanding of SCAD. So I'll be talking about how advanced imaging techniques can help us understand SCAD. And I think, thankfully, going at this time of the day, you are all SCAD experts, and you understand essentially what SCAD is. It is common, relatively common, especially around the postpartum part of our journeys, and is very much more common in women compared to men. But there is a lot of research going on to try and understand the pathophysiology or how SCAD happens. But my work really has been interested in looking at, as Professor Adlam said, how we diagnose SCAD. And the reason why is, at the moment, the gold standard is being able to take invasive X-ray pictures with other what we call intracoronary imaging. So this is using an ultrasound within the blood vessel itself, or again, a more advanced imaging, what we call OCT, to see what the SCAD looks like. But that involves you, as you might have experienced over during your main SCAD event, an angiogram where someone would have gone either into your arteries or into your groin, depending on where the access was, to then put thin wires into your heart, to then inject some contrast, and then take these X-ray pictures, and then seeing where the narrowing was. But as we've already discovered, that increases the risk of further injury to the blood vessel, because especially in the acute setting, the blood vessel is quite frail and more damage can be done. And we know up to 4% of patients, the dissection or the tear itself can worsen. So where research is moving towards is how can we non-invasively get the same information without putting patients at a greater risk. But again, the key thing to bear in mind is that sometimes you do need an invasive intervention to ensure that you're safe. So this doesn't necessarily mean we don't need invasive angiograms. It's just that actually on the day-to-day assessment of patients that we think are less likely to have acute coronary syndrome because of the blockages of the furring of the blood vessels, which most of you don't have, then perhaps the CT might be a better way of assessing the blood vessels. But at the moment, what we do know, and work from my predecessors have already also highlighted it, is that CT is pretty bad at picking up SCAD. It's more or less the same as flipping a coin, really. And that's because typically most of these SCAD that we see tends to be in the middle of the vessel or a bit more lower parts of the blood vessel, where the vessel itself becomes quite narrow. And so the resolution or how good the CT can see the changes can be quite difficult. And sometimes, even when we've done invasive angiograms and demonstrated that there is a SCAD, the CT scans don't necessarily pick it up. And so what my area of research is looking into is how can we augment that non-invasive assessment, or how can we improve the CT's ability to pick up SCAD or to assess it later on down the line once you've had your invasive angiogram, so that you don't need to have further invasive assessment if not necessary. And the way I'm approaching this is using 3 different methods. So the first method is really looking at the anatomy of the coronary vessel to see if there is any information we can glean from the anatomy itself that differentiates SCAD coronary vessels from non-SCAD vessels. And that involves what we call the tortuosity, or how bendy the vessels are. We know from earlier research, especially from invasive angiogram, that SCAD vessels in general can be quite tortuous, i.e. very bendy. But this hasn't really been assessed to the extent that I'm looking at in CT scans. So the first part really is comparing SCAD blood vessels against FMD, against patients with hypertension but without SCAD or FMD, because we know that hypertension in itself also increases the bendiness of the vessel. And then we will compare it to patients without hypertension and without FMD or SCAD. So that's the first bit of my research, actually, and comparing them across the 3 groups. And we're trying to do that with 2 different methodologies. So the first method looks at what we call a semi-automated assessment, where we are essentially using the CT software. So we get the CT scan, then it automatically, we can develop what we call a center line, so a line through the middle of the vessel, and then we can work out how bendy the vessel is based on certain calculations. That in itself, while semi-automatic, can still be quite time-consuming. So what we're trying to do, again, working with our collaborators in Oxford, is to try and automate this process. So you get a CT scan goes in, we get that centerline data automatically done, and then we run the algorithms and then calculate how bendy the vessels are. And again, we're comparing this across the different groups that I've mentioned, but then we also have access to a much larger cohort of patients who have already had the CT scans, who are not necessarily SCAD patients. And that will give us what we call a population-wide bendiness of blood vessels and see where the SCAD patients, the FMD patients fit in, and how much information that can be gleaned from it, and how we can use that almost as an adjunct and as an addition to a conventional CT scan. So the second phase of my research then looks at inflammation around the blood vessel. So we know that in SCAD, especially around where the event is or the bruising is, you get increased inflammation signals, and that's been proven through different tissue samples. And what our earlier research is demonstrating actually is that in SCAD blood vessels, the signal, or what we call the pericoronary fat attenuation index, that inflammation signal, using CTs and some clever algorithms from our team that we're collaborating with, called Caristo, we're able to see a higher signal in the SCAD patients. But this is all preliminary work that we did initially in 38 patients with SCAD, and then also 38 non-SCAD patients. And we're expanding the cohort to over 100 acute SCAD patients, so they've just had the SCAD or within the 30 days, and then also looking at how that changes after 30 days and when you're followed up in clinic, to see how the signal changes, and importantly, how that informs how we monitor SCAD going forward, or whether we can confidently say, actually, after the signal reaches a certain point, perhaps you don't necessarily need any follow-up and things are resolved. And then the final bit of the research really goes beyond what the naked eye can see, and that's what we call radiomics. There's new advanced technology coming through where the AI algorithm can essentially look and see patterns that the naked eye can't see on a CT scan. And again, no one's really looked at how that fits on with SCAD, and also whether that gives any additional information. And the combination of those three hopefully will give us almost like a SCAD score, which means that if a patient with less likelihood of having a bit of furring in their blood vessels come to your clinic and needs some assessment, where perhaps a CT scan may be the best modality rather than doing invasive angiography. But also importantly, more from the monitoring point of view once the event happens. So sort of in a quick summary of what I've just mentioned here, what we know at the moment is that the invasive angiogram is the gold standard only because you can see it, and you can see it quite reliably, but it puts you at a higher risk sometimes, especially if the vessel is quite frail and the wires go down the wrong lumen. And what we've seen at the moment is that non-invasive assessment with the addition of the inflammation score does improve our ability to pick up SCAD at least 15% more than without the inflammation score. And so hopefully, with the combination of those three different approaches to try and understand the non-invasive assessment, we will be in a place where we can improve the conventional CT's ability to then diagnose SCAD. And importantly, there are other CT modalities or CT technology, especially photon counting CTs, which can see the vessel in a lot more better detail than at the moment conventional CTs can do, to try and get to a place where non-invasive assessment is as good, if not equal, to invasive assessment for looking at SCAD. Thank you very much.
So thanks very much. I love working with Charles. And sometimes people will ask me and they'll say, well, am I contributing to the research? I don't feel like I'm, I haven't had a call to come and get a scan or something like that. And these are the sorts of places where you're all contributing to the research in hidden ways. It's like those, the DNA, it's just that blood sample or the saliva sample generates a whole lot of information. And here it's just having your permission that you've, in the consent as part of the registry, to say it's okay for Charles to get your scans and those scans that you had at the time, and to use those scans to try and find new ways to make the diagnosis for SCAD. And so all of you are helping that have consented to participate in the research. Often you won't even know, but someone is beavering away with your scan or your sample, every day of the week trying to get to the bottom of the questions that we want answering. So Anju has sort of emerged, and now we're going to talk about some of those important underlying questions. So go for it, Anju.
So, hello everybody. So my name is Anju and I'm one of the research clinical fellows at Leicester. So basically, I'm just going to tell you a bit about my research project. First of all, I'd like to thank BA-SCAD for this opportunity, and also a big thank you to all the participants, both patients and healthy volunteers who've participated in the project so far. I mean, there's not going to be any research without participants, so a big thank you to you all. Okay, so SCAD research has come a very long way, both internationally as well as locally here in Leicester. And this has led to big changes in the diagnosis and management of SCAD. So over the past years, we now have about 3,000 participants in our registry, which includes both patients, healthy volunteers, and relatives. We've looked at about 300 participants, and we've performed different investigations like cardiac MRI, exercise tests, blood tests, ultrasound, skin biopsies, all in the aim to understand SCAD a little more better. And the more we look at things, the more we learn that, there's more to look at. So basically, you just got to keep going. So my project is looking at the association of sex hormones in SCAD. And we're just going to look at why we want to look at this, and how we're going to look at it, and what we are looking at. So when it comes to why, it helps us understand SCAD a bit better. So we know that SCAD occurs predominantly in females, with an incidence of about 90% in females, and also at specific time points in the reproductive life of a woman. So we want to know what makes females special, and what happens at that specific time point, and what is the role of sex hormones that makes females special. And also understanding this will give us an idea to understand recurrences better, and also maybe to, in the future, prevent recurrences. We also know that chest pain seems to be more common in the premenstrual phase of the menstrual cycle when compared to the ovulation phase. So we want to know what the role of sex hormones is in there. And there's also some therapeutic implications. So use of hormones in the management of post-SCAD chest pain, concerns in the use of hormonal contraception, and safety and efficacy of HRT in peri- and postmenopausal women after SCAD. So how are we going to look at this? So we've got two different groups. So first is the women of childbearing age group. So these are women who are less than 45 years of age, still having regular periods, not on any hormonal contraception. And we're looking for 30 SCAD patients and 30 healthy volunteers. And we are performing investigations at 2 time points in the menstrual cycle. So one when the hormone levels are at the lowest, and one when it's at the highest phase. And they're performing investigations like MRI, ultrasound, and exercise testing, along with sex hormone levels, and then we're comparing them at these 2 different time points. And the second group is the peri- and post-menopausal women. So this is a pilot RCT, a randomized control trial. And this is basically originated from actually patient-led questions, because you wanted to know if hormones could help with post-SCAD chest pain, and also if HRT is safe in women after SCAD. So we're looking at women who are greater than 45 years of age, peri- and postmenopausal, and suffering with chest pain symptoms. And then you'll be randomly allocated into 2 groups. One is the HRT group, and one is the placebo group. So placebo is like a dummy drug, which looks and feels like HRT, but is not HRT. And again, I have no control over it, and you are going to be blinded to it, and I'm going to be blinded to it. And then we perform investigations at baseline before we start these medications, and at 12 months as well, and then we're going to compare them. So then we know how HRT has an impact on these properties that we're going to look at. Okay? So what are we actually going to look at? So we're going to look at certain arterial properties which makes the vessels vulnerable. So properties like arterial distensibility, compliance, and strain patterns. And then we are also going to look at blood flow as well, because blood flow will give us information on what causes chest pain. And then we're going to put in those triggers that we know are commonly associated with SCAD, such as physical activity and emotional stress. Emotional stress is basically tested with psychological stress while you're in the MRI. Nothing too dramatic. But it gives, I mean, if you ask some of the participants who've participated in the study, I hope they don't give you clues, but then they can tell you that it's a fun process, basically. although it causes stress. But it gives us like really valuable information because like as you can see there, it gives us certain values. So those are like blood flow measurements. And we're gonna like, look at those blood flow measurements at 2 different points in the cycle or pre and post HRT. And then we're gonna compare it at rest and at stress. So this would give us like really good information on managing post-SCAD chest pain. Okay, so what have we done so far? So far, with the women of childbearing age group, we've recruited about 22 SCAD patients and 22 healthy volunteers. Most of them have had like the 2 visits, and then we've performed all these investigations that I've mentioned before. And with the peri and postmenopausal women, so we've got all the approvals done, and we are planning to start recruitment from mid-November. And what's next? So I need more SCAD patients, so 8 SCADs and 8 more healthy volunteers, and then comes the process of analysis and results and publication, which I hope will happen soon. And then with the HRT group, like I said, we'll just start recruitment next month. So once again, I'd just like to thank all the participants who have participated. Again, research wouldn't be possible without you guys. Thank you to BA-SCAD again for this opportunity, and to Dr. Adlam, who's been very patient, being my supervisor, and the SCAD team, especially Jane and Jen. And I've just dropped in some posters. So if you're interested, please do use those contact details, and I'll give you more information. Okay, thank you.
So we need your help to answer those questions. So if you are in the age range, have a look at the poster. If you're in the age range and you have chest pain, and you don't have either a myelina coil, and you're not currently using HRT, and you're interested in participating in this study, then we desperately need your help, because we need to get 60 people to participate in that. But if we get that, then we can come back to this conference in 2 years, maybe 4 years. We'll see how we get on. And we can actually give you some proper data from a randomized, blinded clinical trial that's looking at HRT and its effects on chest pain. And we can give you the data. So that, again, we're no longer flanneling. We're coming back to proper data and proper findings. So please do reach out to Anju if you think you fit the bill for that study, and we can talk to you about that, because we're really pretty much ready to go. So tell us if you're interested. I just also wanted to just quickly introduce Mazhar. Just want to introduce yourself as a new clinical fellow who's just joined the team.
Hi everyone, I'm Mazhar. It's a pleasure to be here. I'm really excited to join the team and contribute to the wonderful work that's ongoing, and hopefully make a difference. So thanks for having me.
So yeah, we're still giving him some sleep, but that will pass. And these are just a few people, and I've probably forgotten to mention some people, but some of the researchers who are focused on particular areas have stood up and talked to you today. But there are also people, some of whom you've met, who are completely amazing human beings and help us deliver on all of this research, and that's nationally and internationally. And I also wanted to just introduce you, or not reintroduce you, to somebody who kind of was at the beginning of the whole process and helped us to get the whole thing started and collected a whole lot of the initial data, but also is, running a service, and so many of you will know her from Chelsea and Westminster Hospital. Abby, just say, because she does an amazing job for SCAD in London and has previously collected a whole lot of the data that we've published to date as a part of her work a few years back.
Thank you, Dave. I'm awake. It's an absolute pleasure to be here, and it's wonderful to see so many faces that I've known who've come and said hello, and faces that I've spoken to who now I can relate the name and the face together. And it's amazing to see my colleagues who are doing incredible work, so well done. It's a true honour to have worked with Dave. I think, Dave, what you're doing is phenomenal, and I hope the work will continue, and I'm glad the skin cells that I've collected have not been binned. They've become... It was my delight, those fibroblasts are being grown in a petri dish with some hormones.
They are definitely still going.
It's super exciting. I feel like I've achieved something amazing. But yeah, by all means, SCAD clinic runs in Chelsea. I battle with the NHS ongoingly because they're always trying to close me down and give me general cardiology, and I say no. But feel free. I mean, we're hoping we've been a bit more streamlined because I've got an administrator, as long as I managed to keep his funding going. and hopefully means we can see you in timely manner rather than 10 years later, hopefully within the first couple of weeks, and then see you for follow-up. And thank you to you all for making SCAD very, very special. Thank you. I do love my job because of you.
I think we'll just get whoever we can who's just been speaking just to come and sit at the table here.
Hello. It hasn't been mentioned all afternoon, but is there any link at all between SCAD and chemotherapy? With the
So I can probably take that one. So not as far as we know. So chemotherapy is sometimes associated with other forms, other associations with heart disease, but it's probably just coincidental as far as we know. Certainly isn't something that I've seen frequently in the clinic. It's not something that's come up in terms of the people that I've seen coming through the clinic where you sort of think, well, hang on a second, I'm seeing more patients with breast cancer than or whichever cancer that I'm expecting to. Abby, anything from your perspective that you've seen?
No, I mean, I think my only experience is some chemotherapies obviously raise blood pressure, and perhaps I find some patients who had a missed blood pressure increase due to chemotherapy, immunotherapy, early headache. Sometimes we find that that's the case after psychic SCAD.
Yeah. So just for those, sorry, we didn't get a mic down for Abby, but what she was saying is that there are some chemotherapies, particularly newer ones, some of the immunotherapies that can sometimes push blood pressure up in an unexpected way, and there might be some link between that. But I think I don't think that there's a strong association that I've seen beyond potentially that side of things.
Yeah, it was just a question on the cardio rehab section. So they mentioned, I think there was 2 groups with 30 and each one was a control group. I was slightly unclear, does the control group do no exercise then? Is that how it works?
So I can probably answer that. I'm sure Noemi can answer that. But in essence, we don't instruct them in the exercise, but we don't prohibit them from doing exercise. So if they go to cardiac rehab, they go to cardiac rehab. We're not changing any of that. So we're not changing usual care. We're just adding something else on and trying to understand. So what we find a lot in cardiac rehab is that people say to us, how much can I do? And it's been very much this consensus that was delivered by cardiologists is that they shouldn't do isometric exercise. We don't actually have any evidence to support that. So we're trying to understand these things a bit better. What we would probably say is avoid breath holding. That would be the big message at the moment, because that may increase your intrathoracic pressure. But then again, people can play the oboe and we let them go off and do that, and that seems to be fine. So we're trying to answer these questions. Maybe I'll come back in 2 years and have more to tell you. Noemi, is there anything else you'd like to add?
So if you are participating in the exercise study that we've got going on at the moment, if you are in the exercise group, you can still do your own exercise that you enjoy doing, and you can still participate in your own cardiac rehab. And if you are, again, in the control group, I'm not going to tell you not to exercise. What we are interested in is what you do on your own, and that's very valuable. What we will give you on top is more like a personalised program to you that is very much based on an exercise test that we've done with you. Yeah.
So I think the key thing in terms of how the research works, and it is sometimes a little bit frustrating. We were talking a bit about this with the randomised trial as well, the HRT study, is that if we're going to do it properly, then some people have to not get the treatment so that we've got a comparator group. And what that ultimately means, and this is, I suppose, why research is often altruistic, isn't it, is that you don't know which group you're going to be in, and but you just, you're putting yourself forward essentially so that in the future we have a clearer picture as to what the answer is. And if everybody should be in the intervention group in the future, then great, we now know that that's the case, and we can tell the medical literature that that's what we should be doing. But there's no prohibition on exercise, and to some extent one of the really lovely things about this collaborative study is that it's going to give us information whichever way, because we're really interested to know what is the spectrum of exercise that patients with SCAD do, because there's sort of rumours in the literature that you are more active, but is that really true, or is it just as sort of, something that comes out from looking at patients in a particular context, like in research can sometimes do. So what is the range of exercise you do before you had your SCAD? Obviously, when you have your SCAD, nobody's exercising. And then what's the spectrum of recovery? How is that influenced by chest pain? And also, how is that influenced by the remote intervention that the team are trying to look at? So that's the idea of that. Does that answer your question? Yeah. Yeah, go for it. There's questions on either side of the aisle.
I'm interested in the CT part where you said you are looking at the inflammatory signal. So what will be the difference between the inflammatory signal of a SCAD patient versus a normal heart attack patient?
Yes, so the first part of our study, when we looked at the 38 SCAD patients and non-SCAD patients, we didn't include an end-STEMI cohort, whereas the larger expanded cohort that we're going to look at now, we're going to have SCAD patients and then non-end-STEMI patients, essentially, and then also non-end-STEMI or SCAD controls. So we'll be comparing those three cohorts, actually, to see if there is any difference in that setting. We're also looking at, of course, as I mentioned, the SCAD after the 30 days, so the non-convalescent SCAD cases as well, and doing those inflammatory signals assessment in there to see if, again, there is any change and what the time difference is. So one of the things which I haven't mentioned would be to look at the time of onset or the time of the SCAD events and then the time of the CT scan as well, to see if, again, if that changes our ability to see any residual changes or any changes on this, any features of SCAD on the CT, and then B, if there's any changes in the signal as well, and if actually we should scan early, maybe a bit later on, or not at all.
Yeah, so very quick explanation. We already know that there is a very dense inflammatory response to injury after SCAD. In the location where the SCAD occurs, this is something that we've seen, and we know it's there. In the previous work that was, I think, presented at the last conference, we showed that there's a big difference in that signal between SCAD patients and healthy volunteers, or people that are going through the chest pain clinic, that kind of thing. One of the things Charles is now going to do is, I think, your suggestion, which is not just to compare it to people that are healthy, but to compare it to people that are having a heart attack for another reason. We expect there to be a difference, but probably a smaller difference. But Charles has got a PhD to get, so he hasn't got the information for us. He needs to pull his finger out. So. No, he's doing brilliantly, Should we take one from the pot while we're distributing microphones?
Yeah. Are we any further ahead with knowing what causes the bruise to start in the first place?
What a great question. So we know some things which we've talked about. So we know that there is a genetic vulnerability. We also know that there is probably a role for hormonal changes in the structure of the wall of the artery wall in some way. And then maybe there are roles for emotional stress, maybe high blood pressure, things like that have a play. What we still don't understand very well is what happens on that day. Why is it then that vulnerability happens? Of course, that's also true of many other conditions. We don't really know why somebody has a normal heart attack on that particular day when they've got that underlying disease process, So I think the message that I would say is we've made quite a lot of progress. We now understand that the bruise forms in the wall of the artery first. This is not blood coming from where the blood is flowing in the lumen that's escaping through some rent in the wall that's developed. It doesn't seem to be that, certainly not in most patients. It seems to be that the bruise comes from the outside and then it may rupture in afterwards. We've made quite a lot of progress in saying that there's changes in the wall in terms of those genetic changes in how the wall's connective tissue is glued together and how blood clots in the vessel wall. There's still a long way to go, isn't there, from getting from that to understanding everything, but that's why I'm mercilessly flogging my team every hour of the day to collect more data so that we get to the bottom of it. Yeah.
One for Tina, I guess. Can FMD develop, or do you just have it? Are you born with it?
We obviously don't have scans from when people are born. All we can do is understand when you've got it now and then follow it up over time. So the likelihood is that it's been there for an incredibly long time. Okay. Why am I saying that? Because when you delve back a little bit, there seems to be a higher incidence of patients who are hypertensive now having had high blood pressure when they were on the pill, during pregnancy, things like that. So that implies that there was some potential predisposition at a younger age, it just wasn't picked up. So the vast majority of patients, we don't see changes in the FMD. So the best guess I can give you in the absence of exact scans from a younger age, well, it's likely been there for a very long time.
Do you see FMD in children very often?
We do see FMD in children, which is why I'm extremely keen for Great Ormond Street, who are the centre who are keen to participate in UK FMD, to input their patients, because then we'll have some objective analysis as to how is it different in children, patterns like that. The youngest patients that I've had have been picked up in their teen years, and they tend to have the focal FMD type. So the focal, that causes a more pronounced narrowing, so you're more likely to, so I mean focal in the kidney arteries, so you're more likely to present with high blood pressure at a young age, and somebody suspects, oh, this is not usual.
So we've got a couple more kind of researchy. Is there any evidence why SCAD is more common in females? And then also, is SCAD genetic? So you've touched on a little bit of that.
So the genetics thing, I think we've probably talked through the answer to that. So rare patients with genes associated with other known syndromes, your Marfan syndrome, Louis-Dietz syndrome, vascular Ehlers-Danlos syndrome, and adult polycystic kidney disease, these uncommon things that run in families, only affecting a very small percentage of patients. Most patients, that'll be most people in this room, genes do have a role, and it's these multiple genes that confer risk, multiple genetic risk factors, that seem to be to do with the glue that holds the arteries together, maybe a little bit to do with clotting. The good news, it's always good news, is that those genes actually protect a bit from conventional coronary artery disease, and it's one of the reasons why we think that when we look at the SCAD populations, angiograms, relatively uncommonly do we see much in the way of conventional coronary artery disease in the same patients. So I guess what you lose with one hand, you gain a little bit at least back with the other. So that's the genetic question. And then the femaleness question is really still not fully understood, or even not partially understood. So perhaps a little bit surprising in the genetic studies that we didn't see anything that was very clearly linked to femaleness or female sex hormones. And of course, the work that Rahul is doing at the moment in the lab and Anju is doing at the moment with the HRT study and the Women of Childbearing Age study are really crucial to trying to knit that together from the genetics through to the hormones, through to the patient. How is that all working through that cells thing? My rubbish little diagram from earlier.
It might just be a coincidence, but talking to lots of other people, I say, I'm really, really tired post-SCAD, but I'm also really chronically low B12. And so many people have said to me too. Are there any links? Is there any plan to have any research surrounding that, or am I barking up the wrong tree?
No, I mean, so we've had a few conversations over dinner with different suggestions, different thoughts, and these different thoughts and suggestions are all really helpful because, some of these things we don't know, they're not necessarily checked or so on, but there's still things that, help because if you mention things, then we can start asking about it and see if we start to see connections in other patients. So it's not something I've seen, but it's not necessarily something we specifically look at unless people are known to have deficiencies. So I don't know. Generally speaking, in terms of kind of vitamin type supplements and things, my position would be if you're deficient, then take a supplement. If you're not deficient, then save your money. Personal. Yeah.
Well, there were some similar questions along those lines, really, just about kind of superfoods and various supplements, and just if there's any kind of safety issues with SCAD patients or medication contraindications.
So, for the most part, no, we don't really, there are no studies, but these things are in common use in the population. It seems unlikely that there will be safety problems related to them. Do they help? If they help in terms of you feel better when you are taking them, that's fine by me. I think many of us who don't get out much are vitamin D deficient. Certainly I probably am. So it's because we live in a dark country. I don't have a particular issue or problem with it. I'm not sure that I would advocate using supplements unless you are specifically deficient, because otherwise, for the most part, you're just digesting it.
We have a question about genetics. I had a SCAD and my mum had a SCAD and her mother potentially had a SCAD. We just want to get tested for it, basically, for the blood tests.
Yes.
We would like to see that.
So if you are not already part of the research in some way, then you will be very important to Rahul's work at the moment. Part of the work that he is doing specifically is to collect families. And we're interested in families that, not just families that have SCADs within the family, which is uncommon, but also families that have other sort of vascular related things, for example, brain aneurysms, those kind of things that run in the families. If we see something like that, we're interested in it. In terms of what it means, I don't know the answer because Rahul is still doing his research. Hopefully he's doing it now, which is why he's not. Yeah. I can tell you what I think is more likely to be the explanation. I think that it is unlikely that there is a single DUF gene cause. But if you haven't been tested for that, then you should be. And whether that's a clinic in London or Scotland or here, then we will all be able to see you and help to arrange a test of a panel of genes that are currently recognised as being associated with SCAD. So that can be done.
Excuse me, sorry.
Yes, of course.
Rebecca has a half-sister, so my other beta is from my first husband. Would she be able to be on it as well?
So what we would do is we would usually take one relative, one of you, and test you for a panel of genes to make sure you don't have any of the known genes that are associated with SCAD. It's called an R125 panel gene test. I think it probably used to have 125 genes in it, but it's probably a lot more than that now. So we would do that panel test. But what I suspect is we may not find that there's a single gene because they are pretty uncommon. We need to check it, but what we may find is that just by misfortune, that combination of risk genes, it just happens to be that Dad had some too. And therefore, that uncommonly has managed to combine in a rare scenario with having SCADs occurring, more than one in a family. But we are specifically interested in families like yours and any other families that are in the audience again. If you're not already part of the study and we don't already know if you have a family history that's relevant to this, then let us know, and we/Rahul will be in contact with you to make sure that we've got either your DNA from a blood sample or those delicious-looking saliva kits that you're all looking forward to receiving. Yes?
I just wanted to ask with regards to, you talked about some of the exercise activity. High adrenaline activity, like roller coasters, what's the advice?
I think that's probably by consensus. We certainly haven't looked at it in the exercise study. I suspect that they don't like you going on them if you've had a heart event. That's a general sort of thing that heart patients get. I don't have any strong feelings personally. Dave?
So there are, and this is what you often find in this kind of space, there are a couple of reports in the world literature of, I think, neck artery dissections occurring in the context of roller coaster rides. Now that is the world literature. There's quite a lot of people that are doing roller coaster rides, and this is clearly not a common phenomenon. But it is the reason that it is generally at least mentioned to people that there's a little question mark over those kind of activities. I think it is very difficult to say that that is a high risk because these are a few cases in the world, right? So it's likely to be a low risk. But then you have to weigh up whether you really have to do the roller coaster ride or whether it's maybe a nice, stroll around a National Trust property would give you the same kind of vavoom experience that you're looking for. I mean, the other thing is for, other sort of high adrenaline activities, you will often have, disclaimers, insurance certificates and things that you'll have to look at. So that's things like your skydiving and your diving. Generally speaking with those things, I'm not massively convinced that there's particular risk associated. additional risk associated with them. But of course, SCAD has a small recurrence risk. And if that small recurrence risk happened to happen in the moments before you pull your chute, then that might be unfortunate.
I was just going to ask, this one was an interesting one, because you mentioned about not performing angiograms for checking of recovery. So what we've learned from earlier research, what would be a kind of accepted timescale for artery recovery?
The artery starts to heal quickly. I mentioned a little bit earlier that early on, sometimes patients will get stable angina. So when they exert themselves, they'll get chest pain because the bruise is still there causing the narrowing. This doesn't usually last for more than a few days to a week, 10 days in my experience, which tells you that the healing process has already begun because the artery's probably already healed enough at that moment that you're no longer getting blood supply issues when you're exercising. Most of the healing happens in the first month to 6 weeks. And then there are a small number of patients, particularly those that have big dissections at the top end of the coronary arteries, that take longer. I can think of a patient who had a dissection involving the very top of the artery, the left mainstem, that I watched over the course of about 2 to 3 years and still healed. Just took a lot longer to heal. But that is the exception. In most cases, healing happens quickly and is completed quickly.
So there's a few others that are kind of exercise-related, medication-related. I think we've probably covered those. But I did just want to do a quick mention of this one about specialist support, funding a specialist clinic in terms of Wales, because I know Wales have been challenged to have them referred to Leicester in the past. So.
Yeah. It's tricky. And part of it is kind of slightly a bandwidth challenge for me in terms of setting up satellite clinics and getting the funding to do so. We're currently talking to the British Heart Foundation, I don't know how far that will get, to see if we can get some clinical nursing support into the Leicester service and maybe some administrative support. Abby has done brilliantly, I think, from charitable funds as well in London to get some administrative support for her service. We've kind of lent on the research team to help. Thanks, guys. To keep that service running. So if we can get that, then it gives me the bandwidth to potentially go to Bristol, maybe Manchester, Bristol, to try and set up, which has always been the vision, that we have these services that are a little bit more spread around from the spine that they are at the moment, so that it would be a bit closer. There is potential to set up a clinic in Wales and South Wales. Certainly there's interest. It's just about getting the process together and then getting the funding, which is just a very tricky thing to do at the moment in the current financial climate. So I think at the moment we are focused on trying to hopefully secure the Scottish clinic and then hopefully get some funding together for the English services. So at the moment for Welsh patients and Northern Irish patients, it will be coming to predominantly the Leicester service. Remember that we are very happy to do your consultation on the telephone or online. We know it's expensive to travel all the way to Leicester, and we are very keen to support everybody regardless as to what their means are. So if travel is expensive, we can come up with other ways and other solutions. The clinicians in Wales, we went and gave a talk there, I can't remember, I think 3 or 4 years ago we talked at their main meeting there, and they are very engaged and very keen to support their SCAD patients to get the proper care that they deserve. But we hear that you want a service in Wales, and we will hopefully get there.
Can I just add something to that, Dave? Because I think people assume that it needs to come from cardiology and cardiology need to lead it, and it needs to be somebody within a service that leads it. I don't do any clinical work. I'm a university professor. I'm a nurse by background. And I just became a pest to various people, probably including Dave. So for the clinicians in the room, don't assume that it has to be someone else who does this. You can be the pest and go and get people started on this. And, yes, we're coming to a slight crunch with Scottish Clinic, but we were able to do something. And part of that was about meeting people across Scotland who might do it. But also I went to every cross-party group meeting, and I kept nagging until we got SCAD onto the cross-party group meeting. And then these things are really important. and also take your patients with you. Your patients are such powerful advocates. A lot of my work has been supported by Jill McLagan, who's a Scottish patient I met. She comes with me, we do little roadshows together, and I think those are really important messages. Don't wait for the cardiologists. Get it done yourselves. Go out and find someone, and then come to Dave and say, come up to Scotland once a month for 2 years.
Yeah, I mean, rest assured, we are pretty tenacious people. You know, I mean, Abby has fought and fought to keep her clinic going, and so have we. And now we are fighting in Scotland as well, so we just keep fighting, and we will get to the service that we need in the end. But, you know, we just have to keep working at it. Yeah.
Thank you. Okay, so thank you all to the panel.